All right. Well, it is now 7:30 Mountain Daylight Time or CWIS time, depending on how you look at it. Welcome to everyone who's joining or will be joining the call to the August CWIS case review series. Welcome, everyone. Real quickly, before we get started, just a couple of rules of engagement. First and foremost, the goal of this series is for everyone to learn, both the presenters and the people who are joining us digitally. So questions are encouraged. Please feel free to submit any questions into the chat, and we'll try and get the questions answered or unmute you at the end of the presentation. The more conversation we have, the better about each of these cases, because that means the more we all learn. Briefly, participants, please make sure you're on mute during the presentations. The way that you'll know you're on mute is if the microphone is red on your screen with a little line through it. To briefly review the format, we have 5 to 7 minutes per presentation, and then 5 to 7 minutes afterwards for questions at the end, although those times are always flexible. Another brief reminder, please feel free to register for the next CWIS case review series at the link below on the screen. And also a reminder that all of the prior CWIS case review series that have been presented are available at the same site. So this is a nice educational resource for you to go back and review prior cases. With that, I am going to stop sharing and hand the mic over to Dr. Jamie Tung. Dr. Jamie Tung is a trauma and acute care surgeon here at Stanford, where he works with me in the Chest Wall Injury Center. So with that, I will hand it over to Dr. Tung. And Jamie, you're still on mute.
Sorry, I had to figure out how to unmute myself. Are you able to see my slides, or is it?
It's still not in slideshow mode.
All right. Sorry, technology issues. Let me do it again.
All right, perfect.
Great. All right.
All right, take it away.
Sorry about that. I'm Jamie Tung. I work with Dr. Forrester at Stanford in the Chest Wall Injury Society. One of our cases is from a couple of weeks ago, a bilateral stabilization of chest wall. So this is about roughly a 50-year-old woman who was reportedly hit by a vehicle at an outside hospital. At the outside hospital, she underwent massive transfusion, she underwent an XLAP, splenectomy. She had a grade 4 laceration of her liver, so they packed that, and then they primarily transferred her for her aortic injury, aortic pseudoaneurysm, and an unstable T10 fracture. But of note, she had quite significant bilateral chest wall injuries. She basically broke every rib in her body. She broke bilaterally ribs, left and right, 1 through 11, but I think it's a little easier to go through from by side. And also of note, she had quite a displaced sternal fracture right at the proximal head. In terms of left wall anterior injuries, her second costal sternal cartilage was torn off, and she had a very displaced third rib fracture. On the left side as well, posteriorly, she had displaced fractures. She had fractures from 4 to 10, with 7 to 10 being quite displaced, and number 7 here being comminuted. In terms of her right-sided injuries weren't as severe. She also had right-sided rib fractures 1 through 11, and she had flail segments of 5 to 10, with rib number 6 being comminuted, but the rest were found to be offset and simple rib fractures. So in terms of timing of her case, she came to our hospital first, underwent a TVAR, and then had to undergo stabilization of her spine We had planned to take her actually on post-injury day 4, but there was found to be some new infarcts, cerebral infarcts. So we had waited another day or so until cleared by neurocritical care and neurosurgery. So we ended up taking her on post-injury day 6. In terms of our plan, we knew that we wouldn't be able to do this in one case, just given the length of the case and the need to rotate her several times. So we had our supine for the sternal incision, made our sternal incision, able to reduce a sternal fracture, placed 2 parallel plates on the sternum. And then we approached our anterior left fractures, mostly of second and third. We had to make a perpendicular incision in order to have this exposed. And that second rib and third rib fractures were quite displaced. We could see right into the chest cavity from it. The second rib, we ended up reapproximating with a number 1 PDS to the rib above and below to stabilize it, able to plate the third rib. Before we turned her, so she was supine for this part of the case. We turned her prone in order to get to the posterior fractures on the left side, what you see here. We were able to plate ribs 7 to 10 with her prone. We're not able to do a VATS or intrathoracic cryoablation, given the fact that she started to desaturate, so we did an external cryoablation. So that was the first case. The second case, we brought her back a couple of days later, mostly for timings. We knew we had to separate the cases, but number 2, we actually had a separate rib case that had to go. So we brought her back 2 days later, where we made a more standard, we had her up, left lateral decubitus, right side up. We made a anterolateral incision, and we were able to plate ribs 6 to 10 with 2 plates on rib 7. And these ribs weren't displaced; they were all simple or offset rib fractures. We also had to do external cryoablation for the right side as well. Same situation; she didn't tolerate one single lung ventilation. Post-operatively, she's still in the ICU at day 27 currently. I mean, she's had multiple complications, none of which we believe are from her rib fractures or for the rib plating, rather. I mean, she's had cerebral infarct, she had pulmonary embolism, she's had an IVC filter, she has quite a significant pneumonia post-op. And her GCS still remains very poor, roughly around 5 or 6 last time I checked. But I think physiologically, she's no longer septic after her pneumonia, and doesn't seem to have suffered any more complications since kind of her initial bout episodes. But yeah, so for us, I think this was quite an extensive case. Bilateral rib fractures. We typically go to intrathoracic cryoablation. I think extrathoracic cryoablation is something we may look more into, especially with people that can't tolerate single lung ventilation. In order to get to that, it was anterior left rib fractures. I think it was a kind of a different incision. We cut that perpendicular incision that we connected with their sternal incision in order to get to them. Seemed to work pretty well, even though we had to go through the pectoralis. And then staging procedures, generally something that we don't find a need to, at least at Stanford. I think this is one of our few cases that we've had to stage our procedures, just given the length and the question of the ability for the patient to tolerate it. All right, take any questions.
Awesome. Thank you, Jamie, for presenting your case. I guess one question while we wait for others to come in to the chat, and I would just encourage everyone just joining, feel free to place questions in the chat or unmute yourself if you'd like. One question kind of has to do with the staging. So when do you think about potentially staging a case versus just getting it all done at one time?
I think if we could have gotten it done, I think we've had some cases where we could have gotten them done in a single position, and then probably would have done it in one stage procedure. I think even the fact that we had to have three different positions for this case, I think that's part of the issue. I think which is kind of in combination with length of procedure as well, I think is the other issue. Whether it be physiological stability for the patient and or honestly, surgeon comfort for, having these long cases. I think your efficiency just goes down after the first 5 to 6 hours.
Hey, Jamie, this is Tom White. Hey, that's a really dramatic case. I have about 17 or 18 different questions here, but I'll just ask two. The sternal disruption looked like it was distracted significantly on that original CAT scan. Was that a challenge to reduce? And how did you do that?
It wasn't as bad as we had thought. It was quite distracted. We were able to reduce it. Remember, we used to use a series of right angle, or what we call white right angles, I think, to help reduce it.
Do you can you give us your rationale for using cryo in this patient who, at least from my judgment, was clearly not going to be extubated in a day or two or 5, and had multiple other injuries, which all obviously pain generating. Why did you think cryo was worth the trouble?
I think in my mind, I think there's very little. The downside seems pretty low. Number one. Number two, any kind of extra non-opioid pain modality that we can use for our ICU patients seems beneficial to decrease their overall, the rest of their sedation and opioid usage. So I think that if the cryo was, in my mind, gives any kind of even small benefit, I think it's worth it to do, especially with the extra thoracic cryoablation when we can't do any kind of intrathoracic.
Fair enough. We learned recently that Dr. Bauman and Dr. Kay's paper that it's the cost or the charges to the patient for a single episode of cryo averages about $23,000 or $28,000. So I would just ask you to keep that in mind. If you've got someone who's, well, I'm not, your rationale is a strong one. Certainly, we should always try to decrease narcotics, but in some settings, I'm going to argue that it's probably not worth it. They're going to need narcotics anyway, and so that would be just something to keep in mind. I noticed that you used a plating system that has different configurations and different thicknesses. How did you decide intraoperatively which plates to select? Is it based on the pattern of the fracture, the quality of the ribs, the need for more stiffness or less stiffness? Can you summarize that for us?
Yeah, so the plating system we uses my understanding uses a single thickness for the plates for the rib fractures. The sternal plates do use a different thickness, and for those we do measure them intraoperatively in terms of thickness for selection of plates.
No, I didn't mean the screw length. I meant the plates themselves. It looks like, and Joe, maybe you want to jump in here, but
yeah. So we end up selecting the plate based on the consistency of the rib. So I'll tend to use more flexible plates or thinner plates when we're dealing with ribs that are osteoporotic, which is much of what her bone was. We used thinner sternal plates because her sternum was this lady was actually pretty small. So we had to we couldn't use the wider sternal plates that we typically use. We had to use the thinner, essentially elective sternal plates. But it's really just kind of a decision that's made intraoperatively based on the size of the rib, the consistency of the rib, and the anatomy that you're dealing with and the fracture pattern.
So it sounds like you're trying to match the flexibility or the flexion characteristics of the plate to the quality of the ribs. Thicker ribs, more stress, perhaps. Thicker plates. Is that kind of where you're going, or?
Definitely, yeah.
Okay, interesting. I agree. But
all right. Well, I'm not seeing any more questions coming in through the chat. Dr. Tong, thank you very much for presenting the case. Next, I would like to turn it over to Dr. Klein-Dantis for our next case, who's a thoracic surgeon. We're working as an assistant professor in the Department of Cardiothoracic Surgery at the All India Institute of Medical Science in Raipur, India. So Dr. Klein, if you want to share your screen and take it away.
Yes, I should. Hello.
And Dr. Dantas, we're still seeing just the single slide.
Oh, gotcha. Yes. So, shall I start?
Yes, please. Yeah, thank you. Yeah, it looks
Yes.
great.
I should be presenting on one of the techniques of chest wall stabilization and reconstruction of traumatic phages by a figure of 8 suture with a polypropylene mesh and musculofacial flap, which has been published recently in the Chinese Journal of Traumatology. A 45-year-old male presented with the alleged history of a road traffic accident, referred from a remote center with a stay sutures on his chest, which has where you can see the image here, presented with the left flail chest. He had any other injuries, abdominal injuries or any head injuries. There was no comorbidity or he was not on any medications, and he was hemodynamically stable. So we did a 3D chest CT thorax after ruling of the head injury as well as abdominal injury. He had multiple left flail segments as well as the combination of undisplaced offset and displaced fractures from 2nd to 9th rib with a left lung consolidation as well as pneumothorax. Following this, we took him to the operation room and we planned the procedure following the removal of the stay sutures. This was the image which we could see after the removal of the stay sutures, the flap getting reverted back and the chest defect present. The operative approach was from anterolateral to the posterior approach. We extended the incision posteriorly over here. And the findings, what we could see was the small lung lacerations as well as the fractures which were present in the CT, which was present on the CT thorax was confirmed, and the chest wall defect. There are multiple large fragments of the ribs which we had to excise in order to create a space to move ahead. So the time from our injury to the operation time was 90 minutes for us. And this was not a procedure merely by a choice, which we could not procure the plates, especially the RN synthesis system at the hour of surgery in the midnight. And we had to perform this procedure merely by a chance, not by a choice. And we repaired the ribs, the multiple displaced offset and undisplaced fractures were repaired with the figure of 8 suture. We used a simple polypropylene #1 suture material, non-absorbent, and we maintained the stability of the continuity of the rib. And there was a chest wall defect. Prior to placement of a chest wall, we placed a chest drain, and we repaired the defect with the polypropylene mesh, and we placed a flap which was raised before placing a when we placed an incision. Prior to the planning of the surgery, we just we had to raise the flap subcutaneously as well as facial-muscular. Yes, so we placed the flap over the mesh in order to provide extra stability to the chest wall as well as for the additional support. Patient post-operatively, patient did well. He was extubated after 48 hours. He was hemodynamically stable, and there was an area of skin necrosis, especially at the site of a flap on day 7. Clinically, he had fever, so we had to excise the portion of the flap, and we allowed it to heal by primary intention. And next, on the day 11, patient developed lung consolidation. We had to do the bronchoscopy. We removed the secretions, and he did well later, and he was shifted out from the ICU on day 14, and later he was discharged on day 21. At the 1 month follow-up, there was no paradoxical chest movement or respiratory distress. Even at the 1 year follow-up, we found the chest wall stability being well maintained. And one of the learning point I would like to explain is that it is a simple and easy technique for a rib fixation for fractured ribs. You do not have to separate a periosteum, and the neurovascular bundle is well preserved. Post-operative pain was very minimal. Chest wall stability was well maintained. There was no paradoxical movement. Again, I would like to emphasize on that. And if we have to perform, we can perform this procedure in any of the resource constrained settings. It would not expensive procedure. Definitely, if you do not have a plates, you can go ahead with this procedure. That is what I do. Thank you.
Thank you so much, Dr. Dantas. Great case. And when we were chatting about this case, when you initially submitted it, I know you were talking that you do have plates in the hospital. You just you didn't have them at the time of this case.
Yeah, at the time of surgery, we did not have it. We could not procure at the hour of surgery at midnight. It was a sudden emergency. We lacked it. That's why I clearly mentioned this procedure was not by a choice. We had no choice. It was merely by a chance, I can tell, which got published in the Chinese Journal of Traumatology.
Thank you. Yeah, it's very, very innovative approach, and I think it shows that you can address these patients' injuries without some of the greater resources that we typically get used to, but it just requires a little bit of additional ingenuity. One question I had, that patient underwent a devastating injury and was in the OR very quick. Do you think that had anything to do with the health of the patient going into the operation? Like, were there any comorbidities that the patient was dealing with? Because that looked like a pretty extensive operation and a pretty bad injury. Most of the time, I would say we would not get someone into the OR within 90 minutes necessarily for an injury like that.
Yes, definitely it was an extensive surgery, but it did not have any major vascular injuries in this patient. Most of the injuries were confined to the ribs, especially. So it was maintained very well. The most important was for us maintaining the chest wall stability. We could maintain the chest wall stability with this procedure, with a mesh as well as a flap with a non-polypropylene suture. So that's why the outcome was very fine. If there was vascular injury or any other associated injury, it would have taken some time, or it might not have led to good outcome.
Thank you. And then looking at, there's a question from Dr. Tong who says, nice case. How did you pick your initial approach to the incision, or was there just enough of the injury that you just went through and extended the injury site?
I would like to again, while we removed the stay sutures from the presentation after draping the patient, we could see this, and we extended the incision just posteriorly from here. Slight extension we had given here. We did not do anything. We went through the same defect. We operated through the same defect. We excised the portion of the. We excised certain, and there are a lot of fragmented ribs, broken ribs. We just excised these ribs so that we could create a better defect. And we went through this and we repaired rest of the rib cage. And we did not find any injuries to the lung. There were any minor lung lacerations, which was repairable, not beyond that. There were no vascular injuries at all. So we could go through this, and we did.
Excellent. Thank you. I see Dr. White has unmuted, which suggests that he may have a question. Dr. White, do you have a question?
Well, I'm such a bad typist, as you know. I would never get my question into the chat box quick enough for you to utilize it. But this is a fascinating case. But he just answered my major question: is what did you do with those segmental pieces of rib that are tethered by seemingly only by a little bit of intercostal muscle? It sounds like you debrided those and threw them in the bucket and created a single defect, which is really an interesting thing. So 2 questions. If you had had plates available, would you have used them, and would you have tried to preserve those pieces? Number 1. Number 2, did you do anything in the operating room to mitigate against post-op infection? Did you irrigate with antibiotics? Did you place, any antibiotic in the wound? Did you do anything special in that regard?
The fragmented ribs, we excised this portion. We did not preserve any of the fragmented or the lost segments. whichever the ribs which would be approximated with a simple suture material. And we did not use any of the like plates or screws. We lacked it, definitely we lacked it, but we could maintain the stability of the chest wall only with this two, the flap. We raised the flap prior to the incision, planning of the incision. I just raised the flap. So it was easy for us to go behind this part of the posterior aspect. After raising the flap, we could do it very well. And post-operatively, patient did not have much of the movement. There was a slight movement in the paradoxical movement was present, but it improved gradually on the day 6, day 7. Outcome was fine.
Well, you're clearly being very humble and modest. There was nothing easy about this case. So, but congratulations. It's a terrific, terrific outcome. Do you think there's a chance that this proline will one day manifest infection and spit out, or is he out of the woods a year out?
No, I don't think when you saw it on ribs, I don't think they will cause any infection in the post-operative phase as well, because we have observed the patient for a period of 1 year, and it was later we had published the paper after observing for the period of 1 year. So definitely we do not have any of the reactions, surgical, only post-operative, immediate post-op, we had the surgical site infection. That was due to the tension created by, on the flap. We had riveted the flap. So when we had to dissect tissue, there was some tension. So that created some flap necrosis over the site. But later he improved very well. There was not a problem with any of the infection or anything. I think polypropylene might not cause any infection in these cases, especially for the ribs.
How is the patient's sensation a year out? Does he have like sensation on that side, or was there such extensive disruption that he's insensate?
He has numbness. He has numbness initially. He had numbness for a period of 3 to 6 months when I inquired on his questionnaire. But there was not a problem with his chest movements. Chest movements were fine. The numbness was present, but it prolonged up to 9 months as per the patient. 9 months later, it improved. He told, I can feel sensation now. After 1 year, when he came for a follow-up after 1 year, there was he would feel the sensation at the site of injury.
Excellent. I am not seeing any additional questions in the chat. If you want to stop sharing, Dr. Dantas, I just want to thank again both of our presenters, Dr. Tung and Dr. Dantas, for the 2 great cases that were presented today. Appreciate you guys taking the time to put your cases and put your cases together and submit them. Just a reminder that we have cases, all the prior CWIS case review series on the website. So this case series will be up and available for review within the next probably 48 to 72 hours. If any other questions or burning desires come up in that time. Before we go, it looks like there's a question from Dr. Yang, who has a question not related to today's case. So, Dr. Yang, feel free to query the group here. What's your question?
Can you hear me?
Yes, we can hear you.
I have a question because I have a patient. After I operate on her, and she originally tolerated very well, and she had lesser pain, much lesser pain. And then afterwards, she complained about severe burning sensation at midnight. And this kind of burning pain that made her difficult to sleep or woke up easily at night. And do you guys have this kind of experience? And do you think this is some kind of neuralgia or some kind of maybe allergy to the plate and screws?
Hey, Jesse, this is Tom White. It's nice to hear your voice. Thanks for calling in.
Hi.
You know what? It's not uncommon for neuropathic pain to be worse at nighttime. I've heard various explanations for that, but this sounds very much neuropathic. I doubt it's related to any sort of intolerance to the plates. The patient probably has a neuritis or a neuroma, and I think you should probably direct your efforts at that with neurolytic sorts of medications, and maybe even a neuroablation. But I don't think this is hardware intolerance. I think this is chronic neuritis from her, either from the dissection or from scarring, or maybe a rib that didn't get fixed, or something like that. But this sounds neuropathic.
Okay, thank you.
And Jesse, if you are able to treat it, we would love to have the case presented in full at the case review series. So,
absolutely,
because I'm sure there are other people out there who are dealing with similar issues, and it will definitely generate discussion. So please consider this an open invitation for our case review series.
Okay, I will try my best. Thank you.
All right, thank you. Well, once again, thank you to everyone who presented today. Thank you for everyone who tuned in, and we look forward to seeing everyone next month at the September case review series. So take care and have a good day.
Thank you.